Good day. I'm Dr. Stella. I'm a hospitalist physician at Denver Health, where I work on the inpatient side, caring for people experiencing homelessness. And we are going to share with you today our perspective on management essentials for the unhoused population in a disaster setting. I'm joined today by my colleague, Dr. Ed Farrell, who's one of my community partners from the Colorado Coalition for the Homeless. And I'll let him introduce himself.
Thanks so much, Dr. Stella. Hey, I work at Colorado Coalition for the Homeless, started here in 1994, and I'm lucky enough to do street medicine 1 day a week, work in the clinic, and over the years, intermittently have been in leadership positions, so have been working with folks experiencing homelessness for quite some time.
So here are a couple of mandatory disclosures. I'll let you read through these. Dr. Farrell and I have no relevant financial interests or relationships to disclose with respect to this presentation. So here's a roadmap for where we are going today with our talk. Some learning objectives for you to think about. We're first going to share some definitions, data, and realities on homelessness. And then we're going to talk about what homeless communities are already facing, excuse me, that may impact their vulnerability to disasters. We're then going to share with you some best practices and lessons learned from other disasters to improve outcomes and reduce harms for people experiencing homelessness. So words do matter, and you'll hear us throughout the presentation using person-first language, referring to a person experiencing homelessness or a group of people experiencing homelessness, or PEH. For the purposes of this talk, we are using the HUD definitions of sheltered and unsheltered homelessness. So sheltered would be someone who's sleeping in a shelter or other locations designed for temporary living. Whereas an unsheltered person would be someone who's living somewhere that is not designed for regular sleeping. Excuse me. This could include parks, tents, abandoned buildings, also cars and vehicles. Full definition on the links on this slide. So this could be one of the most important slides of our talk today. Really, we're going to be giving you some generalizations, talking about a group of people who are experiencing homelessness. We want you to remember that when you've met one person experiencing homelessness, you've met one person experiencing homelessness. In reality, this is a very diverse population of people. This is a quote from one of our community advisory panel members here in Denver. Just a good reminder to ground us. So homelessness is a growing public health crisis in the United States. In 2023, there were more than 650,000 people who reported experiencing homelessness on a single January night. This was more people than recorded since 2007, when point-in-time counting began across the United States. And that we really know that this is actually a vast underestimate of the true numbers experiencing homelessness. Advocates believe the true numbers are closer to 1.5 to 3 times this number. And that's because of the people that we're not counting, the people who are experiencing invisible homelessness, such as those in hospitals or healthcare settings, jails, motels, or those who are couch surfing. When we look at the living conditions of people experiencing homelessness, as of this last point in time count, about 40% of them were unsheltered. And we know that unsheltered homelessness has been rising really in every continuum of care that was reporting data. So just important to recognize how many people are unsheltered and more vulnerable to experiencing the impact of disasters. We also know that people experiencing homelessness are disproportionately people of color, and people of color are also disproportionately impacted by many of the inequities that are faced by this population. For instance, people who identify as Black made up about 13% of the US population in the last point in time count, but represented 30% of all people, 37% of all people experiencing homelessness. Asian or Asian Americans also experienced one of the highest rises in homelessness between 22 and 2023. The number of people that identify as Hispanic or Latinx rose by approximately 30% in the last point in time count as well. Also important to recognize that folks who identify as LGBTQ or people with disabilities are overrepresented. And when we think about homelessness is really a manifestation of social vulnerabilities and individual vulnerabilities that raise the susceptibility during a disaster. We think about historical trauma and mistrust and the impacts that has on our community. Lack of access to basic needs to meet survival. Decreased access to healthcare due to structural barriers, crowded or unsafe living conditions, pre-existing health conditions, communication barriers, and limited social support. And we'll talk about some of these things and how they impact vulnerability and should impact our thinking about how we respond. We know that homelessness is a dangerous health condition, and this is why Dr. Howard Koh from Harvard University School of Public Health called it the greatest health equity challenge of our times. People experiencing homelessness have an increase in acute illness and serious infections, such as HIV, hepatitis C, or other infections. They also have an increased rates of chronic and disabling health conditions. So in a recent study in California, a representative study of people experiencing homelessness in that state, 60% of people reported one or more chronic health conditions. They also reported high rates of substance use. So about 2/3 of folks reported using substances. And this is why nationally overdose is the highest cause of death in people experiencing homelessness. Mental health conditions are very common as well. 2/3 of people in the California study reported active mental health symptoms, with depression and anxiety being the most common. We know that homelessness is an independent risk factor for death, and some studies have found that it results in decreased life expectancy by as much as 30 years. We also know that the homeless population is aging. So almost half of single people experiencing homelessness in that California study were 50 years or older in 2023. And this is compared with only 11% in San Francisco in the 1990s. So with this increase in aging comes increased frailty and complications. And this is something that we must think about in our response. This is a study on this data here on the right. The study by Brown and colleagues from UCSF found that a high proportion of people experiencing homelessness have impairments of their activities of daily living. So 40% had activities of daily living impairments.
Thank you, Dr. Stella. You know, in speaking of the things that can lead to homelessness, there's a kind of a famous saying, we don't know who said it, that trauma is often the cause and always the result of homelessness. And this is what I see and have seen day in, day out for years. And we do want to treat people with so-called universal precautions as though everybody has experienced trauma. This graph shows a really important result from landmark study downstream from the work of Dr. Felitti on ACEs from Kaiser, that as people's ACEs score, which is adverse childhood experiences, increases, their risk of lifetime homelessness, frankly, goes up meteorically and is really something we need to keep in mind every time we interface with folks experiencing homelessness. And it really is clear, there's a clarion call from that study and from the work that myself and thousands of folks have done over the years. We've got to cultivate a deep understanding of PEH. We know that all healing occurs in the context of personal relationships, so we have to develop those relationships by creating authentic, effective partnerships with folks. Always need to involve lived experts from the beginning throughout the response to a disaster and day to day, and engage frontline healthcare service providers in any response to a disaster. And, you know, this is just one of those wake you up and sober you slides. I've seen this on multiple mornings coming to work that PEH are already facing a disaster without a disaster being declared. Here is severe frostbite and both hands on the upper right. Pardon me that's a intense slide, and so is the folks in the snow. People who suffer frostbite are very disenfranchised, have 8 times the mortality rate. And I think that when we recognize that many people end up in the street, the reasons are just as diverse as the faces on the globe. One of the reasons is frequently women fleeing domestic violence, and they end up on the streets of Denver on a snowy night in December, and at 10 p.m., they better not fall asleep so that they can decrease their risk of sexual assault, physical assault, and they try meth for the first time, maybe 2 or 3 nights, and the next thing you know, the meth is laced with opioids. This might lead to their overdose. It can lead to dependence. And we've got to be able to step back and humanize people and destigmatize folks instead of demonizing them and using trite, oh, they just need to get a job. It's much more complicated, as Dr. Stella noted earlier. When you know one person experiencing homelessness, it's just one. And forcible displacements of PEH, great study from Barocas, Axelrath, and others, disconnect people from healthcare, and this increases the risk of overdose and death because they are no longer reachable and they have to turn to things that they wouldn't normally turn to. And, you know, here's one thing that's just huge from our colleagues in Miami. David Peary, nice link there, that during Hurricane Irma, there was a decision made in the community against the advice of folks who are connected to folks experiencing homelessness of let's take people voluntarily to area shelters and put them on mental health holds. This is an example, sobering, of what not to do. Instead of using subject matter experts, people from the trenches, people with lived experience to meet, interface, and interact with people in a trauma-informed manner, one at a time, to help people, give people options who are facing disasters. And this would include using inclusive, low-barrier strategies to, you know, we just love to say this, and it's just so true, meet people where they are, ready to be educated by them. We like to talk about the 6 Ps, why folks won't seek care, why they won't leave where they are. They need to take care of their partners. They don't want to lose their possessions, their medications. They're connected to their pets, a great coping mechanism. Many places will never allow pets. They have severe PTSD or trauma. They're fearing the police or INS and deportation, or they have psychiatric conditions. So we really need to have appropriate, diverse settings that people can go to during a disaster. Actually, we need that every day of the year. Perhaps non-congregate shelters, safe outdoor spaces, many other options.
So we're now going to share with you some of our lessons learned from working together during the COVID pandemic. I want to ask you to think about that last slide that Dr. Farrell shared, and the picture of what was happening during Hurricane Irma, and think about what does it look like when we have trauma responsive care at every level of our system. So that could look like going into a shelter, meeting people where they are, or into their encampment, helping them feel safe through interactions with peer specialists, maybe motivational interviewing, helping them understand why it could be a good idea to come and get their COVID vaccine, as we did, going bed to bed together during the COVID pandemic in shelters. Thinking about trustworthiness and transparency. So how are you engaging people with lived experience in the response from the very beginning? How are you using trusted messengers as partners to communicate with folks in a way that is meaningful? Are you engaging peer specialists or street medicine teams, or folks that really have gained trust to help in the planning of the response and some of that communication? How are we giving people empowerment, choice, and voice in what we're doing? And really also thinking about cultural and historical and gender issues, racism that are impacting the response, and how to not re-traumatize people, not make their trauma worse. So we know that harm reduction is critically important. It saves lives, and this is especially true during a disaster. People with substance use can experience serious medical consequences and withdrawal with abrupt cessation. And so it's really important that first responders and shelter staff are trained to recognize potential withdrawal and have the ability to quickly get those folks into care. So partnerships with hospitals and detoxification facilities to make sure people can get the life-saving care that they need. It's also very important when we're thinking about those 6 Ps that Dr. Farrell mentioned, that we're thinking about how can we be more inclusive in our sheltering policies. So wet shelters are shelters where people are permitted to use substances and have the support that they need to be safe, would be an example of harm reduction. During the early days of the COVID-19 pandemic, when the emergency was first declared and there was a declaration of which businesses were essential businesses, we made sure that we were advocating that liquor stores are considered as essential businesses, because we were very concerned about what could happen if we had many people in mass experiencing withdrawal and needing to come to the emergency department or the hospital at a time when hospitalizations were spiking and we were caring for folks with COVID-19. Another example of harm reduction could include supporting encampments to shelter in place. For instance, we found through our research during the COVID-19 pandemic that folks in unsheltered locations such as encampments had lower risk of contracting COVID-19 than in congregate settings. And so how do we support people to shelter in place in their chosen homes? Another important thing to think about is how to tailor your communication strategy. So communication is actually helpful and meaningful. So people experiencing homelessness may not have access to the same communication channels. Sometimes folks are relying on word of mouth or messages from other folks in the community. Many do use social media and text messaging as well, but really it's important to think about and work with your community on what is the best way to communicate with folks. It's important to ensure that communication is simple, concise, and clear. For instance, this is an example of a poster that we co-designed with some folks experiencing, folks with lived experience of homelessness, to try to encourage people in shelters to get vaccinated. And so working with community in terms of what is the best messaging strategy. Thinking about people who are non-English speakers, those who have disabilities. We know that folks that are experiencing homelessness are, many of them have various disabilities. So thinking about that in your response. And not forgetting about the hidden communities, those that may be out of view as well. Really critically important to make sure that you're convening your stakeholders early. Ideally, you're doing this before a pandemic or another emergency. So making sure that your stakeholders are meeting regularly and rowing in the same direction. And so we worked closely to set up a task force, which included our partners from municipal agencies, including our Office of Housing Stability, our public health partners at the city, Denver Health Hospital, as well as our public health agencies, our homeless service providers, Colorado Coalition for the Homeless, as well as our shelter leadership and other people serving this community. We had a lot of challenges that we had to navigate together, working for different agencies with different policies, different philosophies. However, we really were grounded in this mutual respect and this mission to serve people experiencing homelessness and mitigate harms and try to protect people the best we could. Data, timeliness and transparency is a huge challenge. This is where things like a social health information exchange, where there is transparency between health and social service providers, can be critical and helpful, and very important to think about how you're sharing data, what data do you need to share, and to help you understand the needs of the population as well as plan your response. But task forces or other forums where people are in regular communication can really help in improving situational awareness of emerging and really ongoing health threats in this community and how to address those together. And then really, can't say enough about the need for person-centered strategies. And so this means that we need to really figure out how to partner with people that do have lived expertise throughout all of our planning and response activities.
So in conclusion, Dr. Stella and I felt like there were some key takeaways. Number one, involving people with lived experience and expertise from the very beginning and throughout the entire process of a disaster and all the time anyway. Two is really make your motto, meet people where they are, so that we go in with humility and cultural humility to learn from the experts who are the folks on the streets experiencing homelessness. Third thing is to really make harm reduction and trauma responsive care our mantra and our breath everywhere we experience folks experiencing homelessness and throughout a disaster response. And Sarah really well emphasized that it's critical from a macrocosmic level to have key stakeholders aligned and together rowing as one in the response. And then we do have more information and references for you all on the fact sheet that accompanies this talk. Thank you so much from both myself and Dr. Stella.